Namaste. I'll be talking about liquid-based cytology in this presentation. At the outset, I would like to declare that some material in this presentation is taken from internet only for educational purposes, and I have no copyright over this. I do not endorse any device or equipment described in this presentation. Learning objectives. In this presentation, we'll be talking about successful story of conventional pap smear and what are the limitations that led to the development of liquid-based cytology, what are the morphological alterations in the smear as a result of processing through liquid base, and what are the advantages and disadvantages as compared to conventional smear, which help us in choosing a particular liquid-based system. We all recognize Dr. George Papanicolaou, who was pioneer in showing that vaginal smear could diagnose cervical cancer cells. He used glass pipette for collecting vaginal pool material and demonstrated that the cancer cells which are shed can be identified in these smears. He came out with this paper, Diagnosis of Uterine Cancer by the Vaginal Smear, which is considered a landmark publication, followed by a comprehensive book on exfoliative cytology. But George Papanicolaou's tool of vaginal smear was not sufficient to collect the cells from the cervix. So it was Dr. James Eyre who invented this Eyre spatula. It was made of wood and it had one concave end which was meant to connect the cervical cells, and the convex end which was meant to collect the cells from the vaginal wall and the pool. By this time, pap smear was adopted worldwide for cervical cancer screening. In developed countries, through the organized screening, they showed 70% reduction in cervical cancer incidence. The developing countries also, through their opportunistic screening, could downstage cervical cancer to some extent. It was a tool which was very useful not only for the cervical cancer but also identifying cancer from other parts of the female genital tract like endometrial cancer and ovarian cancer, and also it helped in identifying many infections. So it became a very essential part of women health care. Let's look at how the conventional smear was being prepared. With the spatula, the cells were retrieved on the glass slide through up and down motions, and then the spatula was discarded. The smear was fixed in 95% alcohol in a Copeland jar or using a spray fixator. However, the problem was that this spatula was made of wood, so it allowed only 20% of sample to be transferred to the glass slide, and almost 80% of the material was going waste. And because of the delay in fixation, there were several artifacts which appeared, and the way the smears was made, it gave us very uneven, thick and thin areas which were poorly stained. There were obscuring elements in the form of blood, mucus and inflammation, which often hidden the diagnostic cells. And as such, because of the poor retrieval of the material from the collecting device, the diagnostic cells were often not there or very scanty, and they were missed by obscuring elements. So it was realized that our spatula was least effective for collecting cells from the endocervix, which is very important to sample, particularly the squamocolumnar junction, which is the site for the origin of the precancerous lesions. And this material was a wood, and the porous nature of this wooden spatula also hindered the transfer of cells to the glass slide. Gradually, we evolved over these collection devices. Some modification was done in the original IR spatula. The concave, one part of the concave end was elongated so as to collect the cells from the endocervix, and material was also changed to the plastic. Later on, industry provided us better brushes and brooms which are made of very fine material and very acceptable to the patient. So these cervical brush, this is the endo brush, which was able to collect material from the endocervix, and this broom which had lateral bristles for ectocervix and the central longer bristles for the endocervix. However, the problem with the conventional smear persisted. Even we had new devices which were aimed to improve the cellular yield, and we could achieve better sample retrieval, but we could not improve the smear quality because smear preparation and wet fixation, which was dependent on the operator skill, the person who was taking the smear, they found it very tedious and time consuming process, and fixation often got delayed in their busy clinics, and the cytopathologist struggled with these kind of uneven smears. So diagnostic cells were often scanty or absent. We had uneven, thick, dark areas which were not properly stained. There were air drying artifacts. There was cells were obscured by the obscuring elements of blood, inflammation, and mucus. This resulted in almost 10% unsatisfactory rate and high false negative rate of 55%. And we could not achieve a greater sensitivity, although we achieved specificity of 90%, but sensitivity remained at 70%. So it was soon realized that smear quality was dependent on the not only on the collection device but also on the sample taker's skill. With evolution of collection device, we could achieve better sample retrieval. However, it was a processing technique which came in mid 90s or late 90s of the technology of the liquid based cytology, which addressed the problem of manual smear making preparation and wet fixation. So with this technique, we achieved almost 100% cell retrieval from the device. It obviated the need for manual smear preparation and fixation, and it gave us very nice monolayer preparation of cells which were well fixed and well stained. Then the question was it really good? So several studies were performed, direct to vial studies, split sample studies. So initial machines that were approved by US FDA were first one was ThinPrep, which was approved in 1996, marketed by Citic and now marketed by Hologic. They have gone a long way to improve their machines. The initial most device was T2000, which was meant to process only single samples at a time. However, a current version can take a larger load of 20 slides at one time and process both gynae and non-gynae samples. Later on in 1999, SurePath system was approved. So this was the outcome of these automated processing machines. The cells were in a circular fashion deposited on a glass slide in a nice circular fashion and evenly distributed. There were no thick or thin uneven spreading like in conventional smear. So this could be achieved because here not only we achieved retrieval of maximum retrieval of the cells from the collection device, we also achieved good fixation, rapid fixation, and even spread of these collected cells in a standardized manner. So output was always same, this in a very standard, because the processing was standardized and done by the machine in the lab. This is a smear of ThinPrep machine, and this is a smear of SurePath. and under microscope you see these monolayer preparations with such nice clean background. There's hardly any overlap in the cells. Cell morphology is very well visualized. You can see the crispy nuclei, vesicular nuclei, monolayer even distribution of cells in a smaller area, and there's hardly any obscuring elements. So the initial studies of randomized control trial, where they did split sample studies and direct to vial studies, they were very encouraging, and they showed that there is higher detection of intrasquamous intraepithelial lesions, and also they could achieve a lower unsatisfactory rate, which were very encouraging. However, the subsequent systematic reviews and meta-analysis showed that diagnostic accuracy of both liquid based and conventional was same. So it was neither sensitive nor more specific for the detection of high grade cervical intraepithelial lesions. In this video you will see how these machines work and how the smears are prepared. This is for the thin prep.
For years, Hologic has been dedicated to revolutionising the way cytology specimens are processed. The ThinPrep Pap test is the only liquid-based cytology method approved by the FDA as significantly more effective than the conventional Pap smear for the detection of cervical abnormalities. Now, Hologic introduces the next generation instrument to further enhance laboratory processing of cytology samples. Presenting the ThinPrep 5000 processor. Our processor is a user-adaptable instrument. It allows batch or stat sample processing and is also small enough to fit on a benchtop. Preparing the slides and vials for the ThinPrep 5000 processor is quick and easy. Just load vials, slides and filters directly into the processor. Sample recapping allows the opportunity for further out-of-the-vial testing if required. You can even process multiple slides from one sample. The ThinPrep 5000 is able to process gynecological, general cytology and urocyte samples. The processor is a fully automated walk-away instrument. Just load and leave. Unlike other batch processors on the market, chain of custody verification on the ThinPrep 5000 processor eliminates the possibility of sample mix-up by matching the barcode on the vial with the label on the slide. If the barcode on the slide and vial do not match, the ThinPrep 5000 processor will not process that sample and will move on to the next specimen. Using trusted ThinPrep technology, the ThinPrep vial is spun creating currents that are strong enough to separate debris, disperse mucus and randomize cells, yet gentle enough to have no adverse effect on cell morphology. The ThinPrep Pap test filter is inserted into the sample vial. A gentle vacuum is created within the filter. Cell collection is controlled by the ThinPrep 5000 processor. This ensures that just enough of the sample is collected to create an optimal thin layer of cells in a 20mm circle. Following cell collection, the ThinPrep Pap test filter is inverted and then gently pressed against the ThinPrep microscope slide. Cells then adhere to the slide in an even distribution in a defined circular area. Once the sample is processed, the resulting slide is placed into a standard staining rack within an alcohol bath. The operator can then unload the slides at his or her convenience. Compact, reliable, fully automated, the ThinPrep 5000 processor has been developed through years of research collaboration with our customers. The next generation of proven ThinPrep technology, the ThinPrep 5000 processor.
This video is for the short path. You will be able to see how the processing is done in this short path.
Let's take a closer look at the prep stain process. Cervical samples collected in SurePath preservation fluid are received from a clinician's office and accessioned according to the laboratory's protocol. Each vial is checked for proper labeling and is visually inspected to ensure it contains the head of the sample collection device. Specimen vials, centrifuge tubes, and glass slides are labeled. Barcode labels are recommended but are optional. Our proprietary cell enrichment process removes obscuring elements like blood, mucus, and inflammatory cells. This process is what provides the SurePath difference in sample clarity and homogeneity as compared to the conventional PAP method. Once accessioning is complete, a tray of SurePath vials is placed onto a multi-vial vortexer for 15 to 20 seconds. Vortexing randomizes the cell sample, partially disaggregating any cell clusters, and helps free any cells clinging to the submersed collection device. 4 PrepMate processing racks are provided and enable the organization and processing of samples. Each rack is numbered and keyed to accept only its corresponding centrifuge rack. This keyed system is maintained throughout the process, ensuring samples are always properly oriented. A PrepMate rack is loaded with SurePath specimen vials and the corresponding centrifuge tubes. 4 milliliters of density reagent are dispensed into each centrifuge tube. A disposable PrepMate syringe is then placed adjacent to each specimen vial, and the rack is ready to be loaded onto the automated PrepMate accessory. The PrepMate accessory automates this phase. Once started, a disposable PrepMate syringe is loaded and pierces the cap of the SurePath sample vial, mixing the solution to randomize the cellular contents. 8 milliliters of sample solution are then withdrawn from each vial and layered onto the density reagent within the corresponding centrifuge tube. This process automatically repeats for each loaded sample. After the PrepMate cycle is complete, the centrifuge tubes are transferred to the centrifuge bucket for processing. This process takes approximately 3 minutes per tray of up to 12 vials. The 2 milliliters of remaining sample within the SurePath collection vial can be immediately stored or redirected for additional testing. A pre-programmed centrifuge is provided with the PrepStain system and can be used for both gynecological and non-gynecological applications. With SurePath slides, there are 2 centrifuge cycles. The first, soft spin, takes a little over 2 minutes. In this cycle, the density reagent sorts particles based on size, shape, and density. Heavier diagnostic material is allowed to pass through the gradient, settling to the bottom of the sample, while lighter red blood cells, mucus, and approximately 50% of the inflammatory cells remain trapped in the sample layer above. Once the soft spin is complete, the supernatant fluid containing the obscuring materials is removed. Then the second centrifugation, a 10-minute hard spin, occurs and excess fluid is removed, leaving an enriched cell pellet. The samples are then vortexed and are now ready to go onto the PrepStain slide processor. Centrifuge buckets containing tubes are loaded directly into the PrepStain sample area. Labeled slides are placed directly onto the PrepStain slide processor. The processor can hold up to 48 slides per cycle. Note that all tube and slide racks are keyed and can only be inserted in the correct position. Disposable settling chambers attached to the slides define the 13 mm cell deposition area where thin layer preparation and discrete staining are automatically completed by the PrepStain slide processor. Multiple slides can be generated from one specimen if desired, which is useful for processing non-gynecological specimens and for performing repeat testing. Once the slide racks are loaded onto the PrepStain, automated slide processing can begin. 3 processing options are offered from the PrepStain main menu. They are preparation and staining, slide preparation only, or stain only. Once selected, the number of slides to be processed is entered. The system primes itself and the robotic arm moves into action, picking up a fresh disposable tip prior to each sample. It moves to the appropriate tube, dispenses water into the tube, and resuspends the cell pellet. After the sample is mixed, 200 microliters of the cell suspension is transferred into each settling chamber, starting a 10-minute drying phase in which cells gravitate through the liquid and settle onto the slide to create a thin layer preparation. If the staining option is selected, the PrepStain slide processor proceeds with the discrete staining that includes all the common steps involved in a progressive pap stain. Standardized discrete staining eliminates another variable from the preparation process. Stain intensity and tint remain consistent, and the stain never needs to be filtered or reused. Stain bundles have 4 tubes to dispense the staining reagents as appropriate. The longest tip is the aspiration tube, which vacuums excess waste and stain into the waste container. The system provides an audible alert upon specimen completion, freeing the technician to do other things while the automated PrepStain processes slides. During the preparation-only process, slides are dispensed in alcohol. The alcohol is simply decanted when ready to proceed with staining and cover slipping. The prep stain system takes about 60 minutes to automatically prepare and stain 48 slides unattended, or 34 minutes using slide preparation only. Hands-on time to complete the pre-processing steps is approximately 20 to 25 minutes for 48 slides. The end result is a 13 mm circle with a nice homogeneous unobstructed view for screening, which can be done either manually by the cytotechnologist or automatically using the focal point slide profile.
So let's compare the two systems that are available. Thin prep is a little more costly, but it has less preparation time of 30 minutes and it occupies less space because the machine is much smaller than the sure path. It requires less expertise. The difference in fixation is that it uses methanol fixation, which was considered a disadvantage because in pap smear, classical conventional pap smear, we have been using ethanol and we are used to a certain type of morphological appearance, which was improved in sure path, and they started using ethanol as a preservative. The processing system is different, as you saw in the video: centrifugation and then filtration. Here they have density gradient separation and then centrifugation and sedimentation. The area on the slide is slightly larger in thin prep, about 20 millimeters, where in sure path it is 13 millimeter, and as a result it gives little more crowded appearance of the cells. Sure path comes with automated stainer, whereas thin prep gives you flexibility of using either manual or automated stain. So subsequent studies showed that sure path was better in some ways than the thin prep, and possible reasons was: one is in the collection method, where sure path company advised to break the head of the cervical brush and put it into the collection vial. So because of the agitative movement during the transport also, almost 100% of the sample was retrieved, and the cells were fixed in ethanol. It provided excellent preservation. Cell enrichment process by the density gradient removes greater amount of obscuring material, although tumor diathesis is retained. That is in contrast to the filter used in thin prep, where tumor diathesis is also reduced to a large extent. Some studies also showed that detection of glandular lesions is better in sure path because the way the cells are sedimented, the disruption of their architecture, that is three-dimensional architecture or strips and sheets, are less disrupted. And also because of the use of ethanol, the mucus does not stick to the brush and the glandular cells are retrieved into the vial. So overall, what we could achieve by liquid-based cytology. The most important was that we could reduce our inadequacy rate because the cells were better preserved, they were well fixed, and they were not obscured by obscuring material. And the retrieval of the cells from the collection device also was nearly 100%. So there was very minimal wastage. For cytopathologist, another important advantage was that because there was smaller area to screen and there were very few artifacts and background was clean, so it was less tiring to the eyes and the speed of screening improved. We could make multiple slides from the residual material, we could make cell block, we could do special stains, immunochemistry, and also it became gradually, we realized that it is a gold mine for several other uses, which we will discuss in the next few minutes. The disadvantages that were considered were that it was expensive than conventional smear and it took a little longer time in processing. So turnaround time of the lab was longer, particularly in those labs where the workload is very heavy. And because of some morphological alterations, it required training of the cytopathologist, and for the handling of the machine also required training of the technician. So to address the cost factor, some companies came out with this low cost liquid based cytology systems like Cytoscreen, Turbitech, Shandon Babscreen, and which became very popular because of the ease of preparing the samples through these machines, and because of the cost factor. So particularly the developing countries and low budget laboratories adopted these manual methods very easily. And there are others which are coming up: easy prep, mono prep 2, e prep. And some laboratories also develop their homegrown methods based on the same principle as of liquid based cytology, but using the simple machines that they already had in their labs. So not only it lowered the cost, but also it used the simple equipment like vortex mixture to homogenize the sample, and cytocentrifuge, which was already being used by the cytopathologist. The sample collection device, transport medium, and fixative, everything was kept the same. So it was ethanol based fixation, so we could achieve good fixation and no other air drying artifacts. And because of the homogenization and lysis of RBC, the obscuring material was also could be removed. However, advantage was that tumor diathesis remained in the smear, which was considered slightly a disadvantage in the automated systems. The most important thing is, however, these systems, they need ongoing validation. So we can adapt in the lab as and when we get a validated system. Another question arises that how do we report these smears? So this reporting method is the same as Bethesda, everyone follows. Currently, we are following Bethesda 2014 system. The only difference is in the adequacy criteria. Here, for liquid-based cytology, we require at least 5,000 squamous cells in the entire slide, in contrast to 8,000 to 12,000 cells, which should be well preserved. Criteria for the granular component remains the same. It is not expected for the cytopathologist to sit and count these cells. The manual of Bethesda, they provide some reference images that how the slide will look with how many cells. So once we get the visual impression of those images, we can easily assess that the slide is adequate or not. So here you will see how a normal pap slide smear prepared by liquid base looks like. It's the virtual slide. Just we have to note that there are certain morphological alterations which we have to get used to, and it improves with training. As there is minimal obscuring material, the smear is well fixed. There is loss of some loss of background material, so we might miss tumor diathesis if we are not careful. But on the other hand, the infectious organisms are better preserved and easily identified. Cell groups, because they get disrupted, you will have more of single cells, and they may be even dispersed far apart from each other. Whereas in conventional smear, we have been learning that the cells keep their company. So that company which helped us in our diagnosis may not be available in liquid-based cytology. Secondly, another important alteration is because the cells are lying in the liquid for a longer time, they become little smaller. So therefore, increase in the nuclear cytoplasmic ratio may occur, and this can lead to initial increase in the diagnosis of borderline lesions like atypical squamous cells. nucleus becomes little paler. So hyperchromasia may not be as obvious as it is in conventional smear. Nuclear membrane is well visualized. So this might also lead to some missing of the high grade lesions. So we have to be cautious about these initial changes in our reporting pattern, and with there is a learning curve, and with experience this can be controlled. Uh, Now, looking at the other uses of liquid-based cytology, uh, um, we have been using it for cervical cytology since early 2000, and now with the HPV testing, this became a very handy tool that residual material could be sent for HPV testing, and there was no need to take another smear. It could also used for testing for other infections like chlamydia and gonorrhea. Then uses for the non-gynec material, which includes FNAC, brushes, body fluids. Another important use in non-gynae samples is that the samples which are obtained through difficult procedures like ultrasound guided endoscopic material from lungs, from esophagus like EUS and EBUS, which usually are very scanty in their cells. So these small samples we cannot afford to repeat, and if the facility of rapid on-site evaluation is not there, it is advisable to process these small samples in liquid-based cytology so that the cell retrieval is maximum and you do not lose this tiny material, which is the procedure is difficult to repeat. Uh, then we can make the cell blocks also, and therefore we have the morphological comparison from histopathology. At the same time, we can do some immunomarkers. We can do many we can send the sample for molecular testing, because it was found that the cells retain good preservation of nucleic acids for about 6 months in liquid-based cytology. And because of the standardized nature of the preparation of the slide, these slides were well fitted with the computerized automated screening. And with as we are developing artificial intelligence algorithms, these slides are very suitable for that purpose. And virtual slides can also be prepared, and which are much better quality than prepared from the conventional smear. So we are faced with this question whether we should adopt this in our lab, or if we want to, and why we should, and which one we should choose. So from a pathologist perspective, we all were very happy to see the results of liquid-based cytology, because it gave us very good quality smears. So our screening time reduced remarkably, our false negative rate, our unsatisfactory rate decreased, and we could improve our sensitivity. At the same time, it gives us a platform for future automation and also additional tests like HPV testing. So we need not go back to the patient and get another sample. Smear takers were also very happy. In their busy clinics, they didn't have time to to spread the smear on the slide, fix it quickly. Even the training of these smear takers could not help improve the smear quality. So this burden was taken off from their shoulders, and it achieved high acceptability among sample providers. However, from the administrator point of view, it is definitely more costly in terms of initial capital investment, and then running cost, and disposables and reagents, because it is all very customized, so we cannot use other material for these machines. So initially it may be there may be a bit resistance because of the initial cost, but once we can convince our administrators that because we can achieve better productivity in screening, and our unsatisfactory rate. So in the long run, it may be more beneficial. We just have to remember that in initial phases, we might get higher rates of epiugocytology as discussed earlier. So some patients might undergo unnecessary procedures and uh, increased follow-up cost. But this can be gradually controlled with experience. So to summarize, liquid-based cytology is the major technological advancement in our cytology practice. It is as effective as conventional smear for the detection of high-grade lesions. However, the advantage it offers over conventional smears is that unsatisfactory rate can be reduced remarkably. Only thing is we have to remember the adequacy criteria, which is 5,000 cells over the smear or the entire smear. Because of the smaller area to screen, it improves productivity for the screener, and we can perform several other tests from the same sample like HPV testing, testing for other infections, immunochemistry, molecular testing. So we should adopt cervical cytology material model which is most appropriate for our patients. So considering our workload, our budget, we can choose a liquid-based cytology system which is most appropriate. However, these decisions can be reevaluated as technologies are evolving and studies provide more data. And now more and more literature is coming on manual liquid-based cytology and application of these methods to non-gynae material. Thank you.